All right, welcome back, everyone. Our first talk this afternoon is on a topic that I think all of us probably see every day and find very difficult to manage. So I very much look forward to hearing this talk by Dr. Salkinen on refractory cough.
All right, thanks very much, Dr. Frank, and thank you to the organizers for asking me to speak again about the unexplained or refractory chronic cough. My name is Kai Salkinen. I tell people that my subspecialty is general pulmonary medicine. As Dr. Frank said, cough is a lot of what we do. I have no real significant disclosures. I might mention some off-label uses of medications. I am co-editor of 2 chapters in Up to Date on chronic cough. I'm happy to do that. And so what we're going to do today is we're going to talk about what is chronic cough, how does chronic cough happen, things to think about when you're seeing patients with chronic cough, some pointers on the history and the physical. I won't spend much time about laboratory evaluations because this is what we all do. And then cough hypersensitivity is kind of the newer way of thinking about chronic cough, and we can talk a little bit about how that's evolving. And then some of the new treatment strategies that are emerging, and then a few take-home points at the end. So chronic cough is a cough that lasts more than 8 weeks. And rather than calling it idiopathic, the tendency is to call it unexplained, because there's an explanation for everything. And so idiopathic means, oh, there's no explanation, but really we just haven't found the explanation yet. And now there's also a trend to calling it the refractory unexplained chronic cough. Or maybe you found the explanation, but it's still refractory. Then it'd be the refractory explained chronic cough. Like if somebody had a cough that you thought was reflux, but they were refractory to all the treatments, then you'd have to figure out you're just not treating the right thing, or you're treating the right thing, but not well enough. So cough is the most common cause for a visit to any doctor's office, not just pulmonary doctors. It's important because of all the bad things that can happen with cough, not aside from just what it might signify, some underlying problem, but chronic cough, it can lead to cough syncope. How many times have you seen someone who syncopized from cough and then fell and injured themselves? Certainly lost sleep, post-tussive emesis, subconjunctival hemorrhage, which is emotionally distressing. Certainly fecal and urinary incontinence are really quite the issue for many people. Social embarrassment. Lots of people end up skipping church or skipping the symphony because they're coughing too much. I've had a couple of people with incarcerated inguinal hernias from coughing, rib fractures. I'm sure you've seen that. And then people are out of work because of cough, and it's revenue lost. So I like simple visual images. So this is the basic view of the cough reflex on the left. You should be able to see my arrow. You've got, it's like any other reflex. You've got receptors come through an afferent to the central nervous system, and then there are efferents to the effector muscle. So the receptors are cough receptors, which you have in your larynx, in your airways, other parts of the thorax, and then the afferents all come through the vagus nerve to the cough center in the brainstem, which is under cortical control. You can try to suppress your cough. You can make yourself cough. So then the synapses happen, and then the effector nerves go out through the spinal motor nerves, the phrenic and the vagus, mostly to your expiratory muscles to contract your rib cage and your diaphragm to force the air out to make you cough, and also contract your pelvic muscles. So hopefully keep everything inside. So that's the simple version of the cough reflex. And then this diagram is from a New England Journal of Medicine review this year by Dr. Richard Irwin and Mark Madison at UMass Memorial. Dr. Irwin has kind of made a career and a name for himself in really exploring chronic cough, what it is, how to think about it, and how to treat it. And this is just kind of a more detailed version. And so there's 1, 2, and 3. So this is your cough stimulus. And then there's 2 is the cough sensory signaling. And then 3 is the integration, modulation, and amplification of your cough sensory signaling. So just so zeroing in, you've got there's your lungs. And then you've got airways. You come down here, there's the airway epithelium, and then there's branches of the vagus nerve, and you zoom in on those, and you can see there are receptors over here, and then the receptors are stimulated by mechanical, chemical, inflammatory, and tissue damage stimuli, and then action potential gets sent through the vagus, and here's the vagus, and then you also get input from the trachea and other places, and then comes up to the brainstem. This diagram is really just on the afferent limb. It doesn't really show the efferent aspect. It just shows this orange arrow of the person coughing. So that's kind of a more detailed view. It's a nice. The article is a nice review. So Dr. Irwin and others put together this the American College of Chest Physicians cough guidelines in 2006, and they've been since updated and reviewed. But it's a very helpful framework. They divide cough into acute, subacute, and chronic cough. Acute cough is under 2 weeks, and it's either you make sure there's no life-threatening diagnosis like pneumonia or pulmonary embolism or heart failure. If there's a non-life-threatening diagnosis, then it's either going to be an infection, some underlying condition, or maybe an exposure. So that's all acute cough, less than 2 weeks. Subacute cough is 2 weeks to 8 weeks. It's either going to be post-infectious or non-post-infectious, and then that'll be the same workup as chronic cough. And so this is really the framework that I go back to when I'm trying to think, why is this person's cough not going away? It's helpful to come back to a framework to think about for chronic cough, while not being limited to this. It gives you something to hang your hat on, but then you want to open your mind and think, what else could be going on? So usual way to think about a chronic cough is you take your history, your physical exam, you do a chest x-ray. If they're a smoker, or you try to get them to quit smoking. If they're on an ACE inhibitor and it makes sense, you can try to either stop the ACE inhibitor or more commonly switch to an angiotensin receptor blocker, an ARB. And then if that doesn't do it, the cough doesn't go away, then you can go down your algorithm. So that's at the top of your history. Okay, but if the initial history exam and the chest x-ray, they suggest a cause for cough, then you deal with that. But if your cough still doesn't go away, then you go down your algorithm. So the algorithm focuses on the most common causes for cough: postnasal drip or upper airway cough syndrome, asthma, or non-asthmatic eosinophilic bronchitis. Honestly, I don't remember the last time I checked for eosinophils in the sputum. You can also check your FeNO, the nitric oxide. And also reflux. And for each of these, you decide, what's the most appropriate treatment. And then down at the bottom on the right here, they have initial treatments, antihistamines, decongestants for upper airway cough syndrome. There's also nasal steroid sprays, sinus irrigation, all those things. There's antihistamine, the azolastine, those types of things. So for asthma, inhaled corticosteroids, bronchodilators, leukotriene drugs. Now we have the biologics. For non-asthmatic eosinophilic bronchitis, inhaled corticosteroids. And for reflux, acid suppression, diet and lifestyle management, all those things. And then they say other investigations you could consider. A lot of the time you'll have more than one thing going on. Maybe you start with postnasal drip, upper airway cough syndrome, making you have a chronic cough, but then because you've been coughing and increasing your intra-abdominal pressure, you end up causing some reflux. And so maybe you need to deal with the reflux too. Important general considerations: optimize therapy for each diagnosis, check compliance. Like the guy who explained to him how his acid reflux stopped the burning and the brackish taste that was related to the cough and what he needed to do. And I saw him back and follow up, and I asked him, how was the cough? He said, nothing changed. I said, well, did you do all those things I asked you to do? He said, nope. And so, well, why not? I didn't think that was the issue. So you have to kind of make sure people are doing what you ask. And if not, then try to understand why, because maybe there was some communication issue. Due to the possibility of multiple causes, maintain all partially effective treatment. So if there's still some reflux going on, you do that, and then eventually you can pare back on the therapies. So some thoughts on taking the history. Osler said, listen to the patient because he's telling you the diagnosis. And so, like in medical school, they told you to ask open-ended questions. So how can I help you? Tell me your story. How did you end up seeing a lung doctor? Listen for more than 20 seconds. Studies have shown that doctors listen to patients for between 9 and 20 seconds before they interrupt them and tell them what the problem is. I try to let them get it all off their chest because many times they've been waiting a long time for this pulmonary appointment. Maybe the cough has even gone away. And then they ask, doctor, what do you think that was? And so sometimes it can be helpful to think about, even if it's gone away, what could you do the next time it happens? But they've been waiting all this time to see the lung doctor, and they have a lot of questions. So, I take the delicatessen approach. What else? Tell me what else is on your mind. What else? And so, and then often it's the very last thing that they say. This probably has nothing to do with anything. But do you think my cough could be related to whatever? And then maybe that is because maybe they're telling you the diagnosis. So clarify. If you're not clear on what's going on, just say, and if you don't ask them, they're not going to tell you because they might not want to look under the hood and find out that they have lung cancer. So they might not tell you that they've been coughing up blood sputum unless you ask them, any blood? So leave no relevant question unasked. How did it start? Did you have a cold at the beginning of this? Were you exposed to something? Did you move? Have you had this before? Oh yeah, every year, this time when we go and we open up the Cape House, that's when the cough comes or whatever. What makes it better? What makes it worse? What have you tried? All the over-the-counter stuff, alternative things? Is it related to eating? When you get to, if you have neuromuscular disease or you get to be up around 80 years old, the risk for aspiration is pretty significant. So maybe, are you coughing while you're eating or drinking? Or is it afterwards? Maybe that's the reflux. Is it related to exercise? So it may be asthma or heart failure, something in the environment. Are they a smoker? Is the cough productive? Maybe that yellow mucus that they're bringing up every day is, chronic bronchitis or maybe even bronchiectasis. Sometimes people are so used to the way they are, they don't think there's a problem. Like the guy, I asked him, so do you bring up any mucus? He said, no, not really. And his wife is sitting next to him. She slaps him and says, every morning you spend 20 minutes coughing up that disgusting yellow-green stuff. So he's so used to it, but, she can tell you what's really going on. Is it really a cough or is it just throat clearing because of the postnasal drip or just a globus sensation? Or are they snorting, or is it just a nervous tick? So when you're taking the history, be aware of red flags, certainly things that would make you worry that there's something more ominous going on. Coughing up blood is not normal. Smoking is not normal. So, and if you've been smoking for a long time, especially as you get over 40, your risk for all kinds of bad things, not just lung cancer and emphysema, but throat cancer, laryngeal cancer, lung cancer, any change in their chronic cough or a change in their voice. So are they short of breath, either at rest or at nighttime, bringing up a lot of sputum? Is there hoarseness? We think about lung cancer a lot, but, occasionally people develop vocal cord cancer or something. Systemic symptoms, fever, weight loss. These are ominous symptoms. And this slide is from England, so where they spell the esophagus with an O in front of it, so that's why it's gourd and not GERD. But if it's more than just acid reflux, but there's anemia or they have difficulty swallowing or there's blood involved, or they're not responding to therapy, could there be esophageal cancer or stricture or achalasia or dysmotility? Recurrent pneumonias, if it's in different locations, maybe there's something about their immune system. It's the same location. Maybe there's something anatomic. When I was a fellow, I had this guy referred from the walk-in clinic for recurrent pneumonia, and it turned out that he had these little patchy infiltrates, and his presenting symptoms were cough, shortness of breath, and pleuritic pain. And it turned out that these symptoms started after he had injured his leg and it swelled up, and he was actually having chronic pulmonary emboli, and we've just seen a little bit of atelectasis. So anything abnormal on the physical exam or abnormal in the chest X-ray, these are all red flags. There's something else that could be going on. A couple of words about the sinuses. Just because it's such a common cause for chronic cough, postnasal drip, mucus dripping in the back, tickle in the throat, something in the back of the throat. I just can't get rid of that. People won't tell you necessarily that they've had sinus surgery unless you ask them. Or any sinus problems? No. Do you have sinus surgery? Oh yeah, I had terrible sinus problems before that. So that's helpful information. Maybe they had those nasal polyps resected and then they came back. If you're going to have people use sinus irrigation, make sure that they use sterile water, not water straight from the tap. There was this outbreak in New Orleans some years ago. People developed amoebic encephalitis from irrigating their sinuses with tap water that they had not sterilized first. So either boil the water, let it cool down before you squirt it up your nose, or just buy sterile water. Reflux. People might not say reflux, they might say agita, the Italian-American term, or pressure, or fullness, it just doesn't feel right. Regurgitation, the bad taste in the back of the throat, especially if you've gained weight or when you bend over. Symptoms when you lie down to go to bed, especially after a large meal, or symptoms are getting worse after gaining weight. This is a nice diagram. It kind of shows you all the ways that your body can try to protect your lungs from reflux. So here's your stomach on the left side, and then the stuff can go all the way up the esophagus, the pharynx, down to the airways into the lung. So you need all your defense mechanisms. It kind of lists all the things there. So it's a nice way of thinking about it. Things on physical exam, vital signs are helpful, important. Are they tachycardic? Are they hypoxic? Bradycardic? Are they coughing now? Or at rest, or do they only start coughing when they're walking? Maybe that's their interstitial lung disease. If they're not coughing now, well, demonstrate the cough for me. Are they? Excuse me. Are they having visible signs of some respiratory abnormality? Are they stridorous? Are they in any respiratory distress, tachypnic? Do they seem short of breath? Do they have blue fingers? Is there clubbing? Do they have edema? Is there a rash? The cardiac exam, the lung exam, murmur, gallop, growls, wheezes, bronchi. Are they doing a lot of throat clearing or swallowing the mucus from their postnasal drip? So here's an example, a 50-year-old man with cough, chronic cough. It's been going on for months. But he's also short of breath, he's a fever, and a rash. So these waxy pink papules on the knuckles. So shout it out so I can hear you. That's right, Gottrin's papules. All right, he also had a cape-like rash. And he had some interstitial lung disease, as you see here, and he had dermatomyositis with organizing pneumonia. So you have to look at the whole person. Here's another patient, 35 years old. He really wanted to be a police officer. He was overweight, so he lost a lot of weight, got in shape, trained, went to the police academy, became a police officer. But then he started having this coughing, and the cough just would not stop. And it was so disabling. He ended up gaining all his weight back because he just couldn't move around that much. And so he was diagnosed with asthma, but didn't respond to the usual asthma treatment. And here's his X-ray. So it is a lordotic X-ray. You can see the clavicles are way up here, so it makes it look a little bit funny. But beyond that, and he's not particularly rotated. Here's his spinous process is right in the middle. But the mediastinum does seem shifted over a little bit to the left. And he's got the streakiness over here in the retrocardiac area. And so in his CAT scan, the left lung is smaller than it should be. The left lower lobe is starting to lose air. It's becoming atelectatic because of this large, smooth, round thing in the distal left mainstem bronchus. Here's a coronal view. And you can see the atelectasis developing here and how it pulls up the diaphragm. And not surprisingly, when I walked into the room to meet this guy before I had ever seen his imaging, what I heard was, but then I listened to him, it was louder on the left. And here's another coronal view, shows that. And so I can hear people calling it out already. So he had an endobronchial carcinoid. And so he had a rigid bronchoscopy to core it out, and he felt better. I said, Doc, breathing's so much better. But then you have to resect the base too, because they do tend to come back. Usually takes a couple of years before these things get diagnosed because they're so uncommon. But usually young, healthy people can have them in the airway. So always question the diagnosis. Here's a 40-year-old woman with polymyositis, mixed connective tissue disease. The rheumatologist referred her to pulmonary because she was coughing for 6 weeks. She's interstitial lung disease. Is that the problem? Postnasal drip reflux didn't seem to be the issue. She did have probably some restriction. FEV1, FVC are reduced. TLC is a little bit low. Diffusion capacity is low. Not a lot of interstitial lung disease. This stuff persisted on prone imaging, so it's not just atelectasis. And so the cough, and then you take the history, and it turns out that the rheumatologist referred her and started her on lisinopril 2 months earlier, going on for about 6 weeks. So we stopped. So beware of misdirection. Yes, there's interstitial lung disease. So here's another one, 62-year-old woman with cough for a year. And she'd been through all the usual trials of medicines and this and that. Nothing really did anything. Her lungs are clear. She doesn't cough up anything. She feels fine. Otherwise, just cough, 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 cough. Chest X-ray showed the hint of a vertical linear atelectasis in the right lower lobe. And then the CAT scan just showed that, just linear atelectasis. And so I took a history, like, what happened a year ago? Because this cough been going on for a year. What happened a year ago? Nothing really, but I did have this weird thing. I had surgery for a cervical epidural abscess. And so did you have the cough when you went in to the hospital? No, I didn't. Did you have it when you came out of the hospital? Yes, I did. What happened in the hospital? I have no idea. I was so drugged out. So it turns out that she must have aspirated. Let's see. There we go. Yes, because we did bronchoscopy and she had this piece of chicken in her right lower lobe. No infectious symptoms, no sputum, anything like that. So then, where I was working at the time, the surgeon dug it out with some tools, and then the airways were all inflamed behind it, and her cough went away. So, 77-year-old lady with cough for a year and a half. She smoked a little bit. She's from postnasal drip, no heartburns, a little bit of obstruction. Chest X-ray is unremarkable. She'd been through all the usual things. It's a dry cough, getting worse. She used to sit up at night. The only thing that helped her was cough drops, but only for a few minutes. And she had been to see all the specialists. She actually came from another state. It's before computerized records were ubiquitous. And she brought like stacks and stacks of records. And I'm paging through the records while she's talking to me with her family there. And I noticed that what happened was that they'd taken her off her lisinopril, put her on another blood pressure medicine. They tried the nasal steroids, inhalers, proton pump inhibitors. They said there's nothing more they could do, which I take as a challenge because there's always something you can do. Doesn't mean you should do it, but there's always something you can do. But anyway, what I discovered paging through was that they took her off her Zestril, which is like lisinopril. They put her on Vasitec, which is enalapril. Vasitec doesn't have ill in the name, so you wouldn't necessarily think it was an ACE inhibitor. So you could see how that might happen and a lot of things going on. But, once we took her off the enalapril, the cough went away. So let's see, one more. 51-year-old woman with a chronic cough, sinus symptoms, things just weren't working. Chest X-ray, not too exciting. She had a CAT scan. I think it was a pulmonary embolism CAT scan. So it was an expiratory view. Kind of hard to tell what's going on here. So I said, let's get a good view. So we had her come back and do a high resolution CT with a good inspiration. And I don't think it was necessarily read that way, but to me, it looked like some of these airways in the lower lobes are a little bit dilated. I mean, they're at least as big, if not bigger, than the adjacent blood vessels. So I thought, well, maybe this is bronchiectasis. And so her immune workup was pretty unremarkable. But then I thought, diffuse mild bronchiectasis, cough, sinus disease. her ANCA was negative, everything. And so, but I thought, why not check a sweat test? And hers was intermediate. It turns out that she actually had a mild form of cystic fibrosis related disease. So, and then she was better on Trikafta, and so that was good. Things emerge over time. You have to go back to your algorithm, but keep an open mind, think outside the box, revisit the diagnosis, be alert to clinical changes and new symptoms over time. Just in terms of other weird things to think about, not just CF, but inflammatory bowel disease can rarely contribute to cough, but it can give you bronchiectasis. Typically, it doesn't respond as well to antibiotics. Just airway clearance is what you have to do and treat the underlying disease. There's this syndrome called CANVAS, which is cerebellar ataxia with neuropathy and bilateral vestibular areflexia syndrome, which it's a genetic mutation that causes a neuromuscular disease, which is associated with cough as part of it. So something else to think about. Not something you're going to see every day, and probably only in a genetic clinic would they do further evaluation for that. In the interest of time, I'm not going to spend time going over PFTs, imaging, barium swallow, all these things. Symptom control, I mean, this was from a Cochrane review on what the types of things that people use traditionally for treating cough. We're all familiar with benzonatate, dextromethorphan. This is not necessarily an endorsement of what people do. It just tells what some people do. Honey tea, lemon, and liquor, not recommended for chronic cough. Cognitive behavioral therapy, acupuncture, I'll talk about that in a moment. Don't recommend it necessarily. Codeine, I don't generally recommend narcotics for chronic cough, but I mean, there's certainly, if it's a palliative situation, someone with a terminal lung cancer or something like that, or something else, but in usual everyday use, you don't want to give the person a new problem with narcotic dependence. Although I'll show you there is some interest in doing that. This was a study from, I believe, England, morphine for treatment of cough and idiopathic pulmonary fibrosis. And so the blue is the morphine, the pink is the placebo. And after 2 weeks, yes, the cough went down with the morphine group compared to placebo. But as you might expect, there was more nausea, more constipation, more hypersomnia, more lethargy. So I would think it would be only in very, very selected cases, not something you'd want to do on a regular basis. So cough hypersensitivity is the current trend in thinking about chronic cough. And just like you have neuropathic pain up on the top, you can have neuropathic cough. So paresthesias become laryngeal paresthesia. So a tickle or itch in the throat, hypertussia, fumes, think smoke, aspirating, they give you an increased cough response. An allotussia, you cough when maybe you wouldn't normally cough, just from talking or using your voice, like I'm doing now. So they've looked at who has cough hypersensitivity. It seems to be more middle-aged women, 2/3 women. Maybe because at least in the women they studied, it takes less inhaled capsaicin to make women cough than men. So maybe the receptors are geared up, and there are different areas of the brain in women and men that are triggered, and the size of the response is greater. So women have more of a response when they're stimulated to cough. So whereas cough hypersensitivity, when it was first emerging a few years ago, the idea was, well, maybe this is a separate cause for cough. Now the thinking is that, well, maybe it's the final common pathway for many precipitants of cough. So here's cough hypersensitivity syndrome in the middle, and then all these things around the edges can lead to cough hypersensitivity, and it can be more than one. And refractory chronic cough could be any or all or some of these. The idea is that, so for example, if you have reflux or dysmotility, it causes irritation in the larynx, and then the nerves get revved up, you get more nerve endings, they're more sensitive, and then that makes you cough. So that's kind of the theory in evolution. In terms of, just to go back here, so I think somewhere around here, obstructive sleep apnea is on the list. So the idea, for example, with obstructive sleep apnea, upper airway mechanical trauma, all that, causes inflammation, Which causes the nerve endings to increase and to be more sensitive, leading to chronic cough and cough sensitivity. Arousals from sleep with increased transdiaphragmatic pressures, leading to reflux, further irritating. And intermittent hypoxia, I guess so. I mean, if you have hypoxia to the mucosa, then maybe that could cause some long-term inflammation. So people tried gabapentin for chronic cough. It works for neuropathic pain. Why not for neuropathic cough? And, it improved the cough-specific quality of life, the cough severity, cough frequency. I've had mixed results, and as I'm sure you have. And the initial studies were 300 3 times a day. I usually start low, go slow, 100 3 times a day. It even comes as a liquid, so if 100 makes them too sleepy, you can use a smaller dose in a liquid. There was that recent study, gabapentinoids, risk for severe exacerbation in chronic obstructive pulmonary disease. This was people who are on gabapentin not necessarily for cough, but they were for epilepsy, for neuropathic pain, other chronic pain, and all indications. And so there was an increased risk for severe exacerbations, maybe at least partly due to sedation and maybe risk for aspiration. So I'm not a huge fan of gabapentin for chronic cough, but in the right person, it might help a little bit. So here's another person coughing. And so here's another view of all those, the vagus going from the airway to the brainstem, and you've got all these cough receptors. Here's a view of the nerves in the airway epithelium. And as I mentioned before, the nerve densities increased in the epithelium. So on the left is someone who's a control, presumably without chronic cough. On the right is someone with chronic cough, more nerve endings in the epithelium, not in the subepithelium. And then so here are these receptors. And so the P2X3 is one you may have heard about. And then, so there's in the interest of time, I'm gonna go, you don't need to know the P2X3 pathway. But the idea is that here's the receptor, you get a tussive stimulus here from like reflux or allergens or something, and it stimulates your epithelial cells. They release calcium, then ATP goes to your P2X3 receptor. This is the action potential gets generated down the vagus. And then, so here's the vagus going up to the brainstem, makes you cough. So gefapixant, it seems to work it's a P2X3 drug. It reduces the cough, see how it goes down, but dysgeusia, abnormal taste, it really is a problem, and is also dose dependent. So 50% of the people on 50 milligrams of gefapixant get dysgeusia. So, and then this is a recent review. It shows that it may provide some benefit to patients with refractory or unexplained chronic cough, but the magnitude is likely small, and the risk of adverse events, particularly taste-related, remains substantial. So that's why it is approved in other countries, but FDA chose not to approve gefapixant here. But there are other drugs that people are using. Aprepitant, which is already being used for nausea, maybe helped a little bit with cough. These others, and then all these other pixants over here. Couple of words about speech pathology. I'm a fan. If you get someone with a chronic cough, even if you have some other explanation, but they've really developed such a terrible cough, it's disrupting their life, a speech pathologist who is dedicated to helping people with chronic cough can really, really help them with techniques. It involves education, cough control techniques, vocal hygiene training, and psychoeducational counseling. So more in detail. So it explain what is the purpose of cough, how can you identify the urge to cough and maybe swallow instead, or control breathing, breathe through the nose. Vocal hygiene training, reduce the reflux, reduce the hard glottal stops on the larynx, the phonotraumatic behaviors, all these types of things. They have exercises that you can do to relax your larynx. I have at least one patient who, as long as she blows bubbles with her straw to relax the larynx, she's okay. If she forgets to blow her bubbles, her cough comes back. There's some interest in the superior laryngeal nerve block. I've had patients ask me about that. There's some places that do that and say that it seems to work, but this was a review from the Journal of Voice. and they said that and there's only been a few studies. They're small, not long term, and we don't really have enough information. I think it's really reserved for kind of specialized places where they have an expertise in that. And even then, I don't know. The colleagues, I've asked at least one colleague of mine who said, yeah, we've tried that, but we have mixed results. So it's not yet ready for prime time. I told you to talk about acupuncture just because, what else is out there. People try all kinds of things. In general, I have no objections to cupping or acupuncture on parts of the body that are not the thorax. But I get nervous when people put needles in the chest. So this review, this from the Journal of Integrative Medical Research, there are a lot of studies, mostly from China, using acupuncture for chronic cough, and then these are the BL13 and others. These are the places, the locations where they put the needles. And I looked these up. These are all in the thorax. And I would recommend against putting any needles in the thorax because I've had 2 patients I can think of who developed tension pneumothorax from acupuncture in the thorax. They're both older, very, very thin women. So the distance from the skin to the pleura is like 1/4 of an inch or something. But one of the ladies told me she had acupuncture. They put the needles in the chest. I think it was for something other than chronic cough. But they put it, and then as she was leaving the acupuncture place, she said, I'm not feeling great. I'm kind of short of breath and my chest hurts. And they just said, oh, you should go see your doctor. So, and she got worse as she was going to the car, and then she continued to get worse. So she drove herself to the hospital, which was down the street, and she had a tension pneumothorax. From where they'd been putting the needle, and it went too far into her pleural space. And so they put in a chest tube, but unfortunately, she was an older woman, and I'm guessing that her intercostal arteries were a little bit tortuous. So she had a chest tube placed, an artery was nicked, and she developed a hemothorax. So, even though acupuncture is probably low risk in general, it's not zero risk. So I would avoid needles in the chest unless it's for a medical purpose. So some take-home points. So it's the unexplained refractory, rather than idiopathic cough. The history is where it's at. Take a careful history, revisit it, go back. Did you do what I asked you to do, or what else could be going on? Revisit the algorithm, but don't be wedded to it. There's always something you can do. Doesn't mean you should. Question the diagnosis. Is this really asthma? Look at the whole patient. Beware of misdirection. Yes, they have interstitial lung disease, but maybe it's the lisinopril causing the cough. And then be aware of the new drugs, none of which are available here in the U.S. For chronic cough, and think about for the appropriate person, voice therapy. And with that, I will stop and thank you very much for your attention.